is being recorded. You can think generally that it's performing an inhibitory role on the anterior horn cell. So we have here in green the anterior horn cell going to the skeletal muscle, and we have the afferent coming from the skeletal muscle to the anterior horn cell, or the lower motor neuron as it's also called. And this is what we have the reflex arc over. And so you probably remember from A levels talking about the reflex arc when there's a painful stimulus, and even before you can think about it, your body removes your area affected from that painful stimulus. So what the upper motor neuron generally does is it integrates all the various inputs from the thalamus, from the corpus callosum, so the other side of the brain, to generally perform an inhibitory role on the lower motor neuron. So when that's not working, you can think of the skeletal muscle as just generally being hyperreflexic, hypertonic. And whereas if you cut the lower motor neuron, you can just see that you can't exert any influence over the skeletal muscle, and so that's why you can sort of think of it as going floppy, and you can't really control it. So there's flaccid paralysis is how we term it. If you want to look at any further reading for that, this is a really good article on just why it is, but we didn't go into too much depth there. So some clinical signs. So when you're performing clinical examination, you start off always with inspection. So is there any wasting fasciculations? Is there any abnormal posturing? Because that can show a certain pattern, a dermatomal or a myotomal even, sorry, pattern of the weakness. So some patients, as we'll see, have an internally rotated arm when they have certain lower motor neuron problems. Some patients who've had strokes sort of have this flexed upper limb because your flexors in your upper limb are stronger. And then when we talk about the tone, we can talk about whether a patient has a hypotonic limb, which is quite difficult to assess, but you can do so in the rolling leg test, or you can assess whether whether they have spastic tone, which we've talked about, so the spastic catch, or are they rigid, which you find with a few extrapyramidal problems. In terms of power, you have the MRC grading system. So I didn't go too much into that, but in terms of power, you can think 5 is normal power, 4 is slightly reduced power, 3 is you maintain, you can work against gravity, 2 is you can work when gravity is removed, 1 is, oh, I've mixed this up a bit. I'll include that in the notes afterwards. I do apologize. So 0 is no power, 1 is you can work with gravity removed, and then it goes up one by one. And also which dermatomes are affected. So in terms of reflexes, when you do a reflex, you can be hyporeflexic, which is just something you learn to judge over time. You can be hyperreflexic. So you can see, particularly with patellar tap tests, the tibial reflex, you can find the patients will actually just kick out fully. And you can also see this will be reflected in the same dermatome. So it's good to know your myotomes and your dermatomes for this. Any special tests? So we talked about Hoffman's earlier, that, and Babinski's sign, which we also discussed, indicate an upper motor neuron problem. So clinical investigations, when you come across an upper motor neuron features, generally what you're thinking is there's either a cranial or a spinal problem. So you can do a CT head or an MR head and an MR spine. It's generally good at identifying things. So imaging is the mainstay of your investigations. And then when it's lower motor neuron, it's generally electrophysiological testing. So things like nerve conduction studies can detect that quite well. So we'll just get on to our first case. So there's an 18-year-old student who's developed a right wrist drop. So by wrist drop, we mean his hands almost flaccid, hanging down like this. He noticed it after a night of drinking on the town. So any ideas what might be affected? Okay, first of all, what do we want to know about the wrist drop? I do apologize. So in terms of your history, you want to know, and this applies throughout, particularly neurology, any neurological problems. So when we find out the onset of certain problems, we can determine a lot about what the underlying etiology is. So if you think sudden onset, it's generally something that's vascular or traumatic. If it's subacute, then you think, is it cancer? Is it an inflammatory disease? And on and on. And chronic is more degenerative things, so you can think like Alzheimer's and whatnot. Then if you think of the distribution of weakness, that can allow you to anatomically localize various things. So on the basis of the nerves that supply it, or on the basis of the nerve roots that supply it. Whether it's bilateral or unilateral. So if you think in the spine, if something affects the spine and it affects all the spine, it's going to have a bilateral effect. But if you have a focal lesion in the brain, usually that's only going to affect the contralateral side. And you can think of more generalized processes, such as motor neuron disease, that will be more bilateral, whereas if you have a space occupying lesion in the spine, that's going to be the space occupying lesion anywhere, that's going to be more unilateral. And then you can think of associated symptoms, so is there pain, and we'll get onto that. So on examination, you want to do an upper limb neurological exam and a musculoskeletal exam, and the findings on this patient is we noticed so for the history, he noticed this a few days ago in the morning. It's unilateral, no pain, and there's an associated pins and needles on the dorsum of the hand. On examination, there's no wasting of fasciculations. There's a flaccid weakness of the wrist extension, and he can only work it against gravity, so that's 2 out of 5. He can only lift the wrist above gravity, so if you give him any resistance, it just flops back down. It has a normal tone and a reduced triceps reflex, and he has no loss of sensation. So can anyone tell me if that's going to be a lower motor neuron or an upper motor neuron problem? Okay, so if we look at the fact that it's a flaccid weakness and reduced reflexes along with that, that makes you think of a lower motor neuron problem. So this patient has a radial nerve palsy, or what we call Saturday night syndrome. So a lot of patients, when they sort of pass out drunk and they sort of lie on their arm like this, they can compress their radial nerve, and it can cause them to have radial nerve dysfunction for a few days or weeks thereafter, just because they're compressing it in the spine, the spiral groove going down the back of the humerus. So the pathogenesis is just the compression of the radial nerve in the spinal groove, spiral groove, and you get a weakness over sort of the beast muscles is what they like to say. So your brachioradialis, your extensors, your abductor pollicis longus, your supinator, and your triceps. And you also get this sensory loss or sensory disturbance over the hand. So with this, he had a paresthesia over the hand. So I'm not going to go in too much depth into the neuropathies, but when you're thinking of neuropathies, which are all lower motor neuron problems, you can think of mononeuropathies, polyneuropathies, and they have a mimic in myopathies. So polyneuropathies, in the name, it means it's affecting a lot of nerves, so it tends to be a more systemic process that's affecting a number of nerves, and these tend to occur on the distal parts of the limbs. So if you think something like Guillain-Barré syndrome, which you might have heard of, something you get after you get diarrhea and vomiting, that affects the distal limbs. So you might find you get wrist drop and ankle drop, as opposed to myopathies, which tend to affect the proximal limbs. I haven't gone into too much detail there because I don't think you really need to know that at this stage in second year. And then you can have your mononeuritis multiplexes, which is certain mononeuritides, mononeuritis, which affects just one nerve, but it affects in various places across the body. So there's no real pattern, unlike with a polyneuropathy or a myopathy, or indeed a mononeuropathy. Okay, so cases 1A and 1B. We have case 1A, where a 2-year-old child has been brought in by his mother. She's concerned as he holds his right arm in a strange way compared to other children. On inspection, you wrote that the right upper limb is internally rotated at the shoulder and the wrist is flexed. On further history, you note that the patient had an obstructed birth. So this is sort of a quintessential presentation of a certain type of brachial plexus injury. Anyone want to hazard a guess to what it might be? That's all right. So this is what we can call Erb's palsy, which is an upper brachial plexus injury, which a lot of kids, if they get obstructed at birth, if you think they're getting a lot of pressure down on their shoulder during that birth, that can cause long-term damage to the upper brachial plexus. And then you have an opposite here. So a builder presents with a clawed hand, so weakness of the intrinsic muscles of the hand after falling out of some scaffolding. As he was falling down, he grabbed something onto a rope as he fell to try to break his fall. So this, you have the opposite problem, where instead of a force pushing down on the shoulder, you have a force pulling up on the shoulder, and that can damage the lower lower nerve roots in the shoulder, and that's called Klumpke's palsy. So that can just be something you can impress your consultants with on the ward, maybe, who knows. So we've got case 2A, so a 40, and we're moving on to an area now that I think causes a bit more of the confusion when we're talking about upper and lower motor neuron nerves. And so a 45-year-old woman develops a sudden back pain. She also describes pain going down both of her legs and gait abnormalities. She's had one episode of urinary incontinence and several of fecal incontinence. So as I was talking earlier, if you're thinking about onset and then you have a sudden onset, then that makes you think, okay, could this be vascular or could it be traumatic? They tend to be the two things that have sudden onset. So if you think sort of the most classical sudden onset is the thunderclap headache, that's extremely sudden. Within a minute, it reaches its intensity. But obviously this is the back. So something like this, you're thinking if she has a sudden back pain, has she slipped a disc? Or does she have some kind of fracture? She also describes pain going down both of her legs and gait abnormalities. So when you're thinking about shooting pains down both the back of your legs, then you're thinking about radiculopathy, which is nerve root pain that you don't always get with nerve root disorders, but if you get shooting pain down the backs of legs, then you start thinking definitely root pain. Sciatica is the general term for it. And then urinary incontinence and fecal incontinence. Now, this is where you can start to worry, because this shows an autonomic dysregulation. So where is the lesion? So you're going to have to perform a full examination on this, but if she has gait abnormalities and she has, so you're going to have to perform a full examination on her, sorry. So this lady here, if we say she has a flaccid gait abnormality going down two sides of her legs, we're going to start thinking she has a lower motor neuron problem. And so with lower motor neuron problems that occur bilaterally, we're thinking of something that has to be below what we call the conus medullaris, which is something we'll be talking about in a bit. But it's the bottom of the spinal cord before it goes into the cauda equina. And so all the nerves going through the cauda equina, they're all lower motor neuron nerves, lower motor neurons, sorry. So that could be what we think is going to be there. And so what could the lesion be? So it's sudden, it's painful. So most likely this is going to be a slipped disc. What motor signs will she be showing? So as we've talked about, it's the lower motor neuron. So it's going to be a flaccid weakness, hyporeflexia, and hypotonic. And why does she have urinary incontinence? Well, when there's a slipped disc, it can compress the autonomic side of the nerve. So you can, there's a good way to remember this in that it's S2, S3, S4, keep your shit off the floor. And that is, or less rude versions are equally available. And so these control your autonomic regulation of your fecal outlet and your urinary outlet. So this lady will have urinary incontinence because the urinary sphincters are normally jammed shut, but she's going to have overflow incontinence because she can't control the opening of this urinary incontinence. Okay, case 2B. So you've got a 38-year-old woman who's bounced off a trampoline. She's been put in a neck brace and complains of severe neck pain. A CT cervical spine reveals an unstable fracture at C7 impinging on her spinal cord. She has a power of 0 out of 5 in all her limbs. Okay, so questions with this. So which movements will be affected? So if we think it's just going to be everything under C7. So if we remember our myotomes correctly, which is always a bit of an issue, we'll know that C7 controls all the extensor movements. So she might not have affected extensor movements of the arm because the cervical spine goes out underneath. Sorry, in the cervical spine, the nerve root goes out above the vertebral body, so it could be spared by the fracture. But every other movement below that, so she might still have extension of the upper limbs, but she won't have flexion of the upper limbs. Will she exhibit hypertonia or hypotonia? So in patients in which they have spinal trauma, they have something called spinal shock. So this lady is going to have the upper motor neuron affected because she's having this corticospinal tracts affected throughout. The corticospinal tracts are being impinged upon in her spinal cord, and as we discussed earlier, they're going straight from the Bett cells, so it's going to be an upper motor neuron lesion. But acutely following spinal injuries, you get a spinal shock, so you get a flaccid paralysis, and you also get hypotonia immediately after, but it develops into a hypertonia thereafter. So yeah, as I said here, you get a spinal shock and an initial flaccid paralysis following a spinal insult, and it develops into a spastic paresis / plegia in the weeks and months following. Okay, take case 2C. We've got a 68-year-old man with a history of small cell lung cancer that presents to the GP within a month, with a 1 month history of leg weakness and bowel incontinence. He has an associated pain in his thoracic spine. So this is one of your classic malignant spinal cord compression presentations. So questions: how can you localize this patient's lesion on examination? So though this is a though this is a upper motor neuron, lower motor neuron lecture, you can use sensory information from the examination to localize lesions, which is really useful, particularly for thoracic lesions, which is probably what this guy has. And so you can determine the sensory level, just going up, feeling up his trunk. And if you think about the dermatome, so T10 is at the umbilicus, and then T4 is at the nipple, I believe, and then T12 is at the groin, essentially. You can use that to localize at what level the lesion is. What might you expect the underlying pathology to be? So as I said, it's going to be probably a malignant spinal cord compression, as we've established. He's got a history of small cell lung cancer, so that might have metastasized. So this is sort of one of the big areas where people get a bit confused when it comes to upper and lower motor neuron lesions. So with myelopathy, so that's affecting any area above the conus medullaris, the spinal cord proper, you get an upper motor neuron lesion above the conus medullaris, which stops in T12/L1 in adults. And you might also have lower motor neuron signs at the level of the lesion with upper motor neuron signs below. So if you think about it, if you get a compression at a certain level, it might be compressing the anterior horn cell at that level, but everything below it's just going to be affecting the efferent tracts, and so you're going to get an upper motor neuron lesion, but you might get a lower motor neuron lesion at that level. And when you get impingement on the cauda equina, it's all lower motor neurons. Does that make sense? I'm sure we'll hear in the chat after, if not. Okay, so a 78-year-old gentleman with hypertension and diabetes presents to A&E with right arm and leg weakness. This is developed over the last 2 hours. So what have we got here? We've got an older guy who's got a history that might suggest he has vascular problems, presenting with weakness. We don't know what kind of weakness, and it's developed quite recently over the last 2 hours. It's quite an acute presentation. So questions. So what constellation of symptoms would you expect with this weakness? So this chap most likely has a stroke, and that's going to be top of our differentials here because he's developing with a unilateral weakness. So it's not bilateral weakness, a unilateral weakness on one side. So if he's got a stroke, he's going to be having upper motor neuron problems. So when you're thinking about upper motor neuron problems, it's the hyperreflexia, the spastic tone, the hypertonia and everything like that. And there can also be a degree of not spinal shock, but cranial shock, I guess, that you find associated with this weakness that can mean that patients who have had a stroke and have motor neuron features actually present with a more lower motor neuron picture, but that's going to develop into more upper motor neuron picture as the disease course progresses. And so with this sudden onset, what would you expect to be the underlying pathology? So I've given that one away. It's going to be probably going to be a vascular pathology. So you would expect to, because we found the chap has developed right arm and leg weakness, we're going to expect, because as you're probably familiar, the corticospinal tract decussates at the pyramids, and so you're going to expect it to be a contralateral lesion. So he's probably going to have a left-sided stroke. And so what would your initial investigation be? So when someone has a stroke, you want to exclude a hemorrhage before you do any treatment. So it might be a hemorrhagic stroke or it might be an ischemic stroke, but you want to exclude the hemorrhage because that's a neurosurgical issue. So you're going to do a CT head, exclude the hemorrhage, and then you can do either a medical management or a neurosurgical management. And so what gait is associated with this, I imagine I was going to say. So you get a hemiplegic gait, which is where you get sort of a spastic extended leg. So they have to rotate their hip around as they're walking along. And I can get a video up of that if you're not familiar with that at the end. So intracerebral lesions will have upper motor neuron features. They'll be contralateral to the side of the pathology and less with cerebral palsy, which whilst they're still developing, you might have a bilateral features. And they may have other features to accompanying these lesions, which is quite common, such as higher function, negative and positive symptoms. So they might have language disorders or visual disorders that accompany this. So case 6, a 45-year-old woman presents with a facial droop that she noticed this morning when getting ready. She's worried that it may be a stroke. So you probably remember that campaign we had a few years back that was FAST, which is face, arms, speech, and time, I believe, for detecting stroke. So it's actually not that common that people do get a facial droop with their stroke. They do. But when you get a facial droop, it can be an upper motor neuron or a lower motor neuron issue. So an upper motor neuron issue could be a stroke or multiple sclerosis, or a lower motor neuron issue could be Bell's palsy, Ramsay-Zoster syndrome, which is essentially shingles of the face. We can get a Guillain-Barré syndrome, which isn't as often unilateral. So the reason earlier on we had that question on is it forehead sparing or is it not forehead sparing, and this is sort of a brief an explanation of why a forehead sparing issue is going to be an upper motor neuron or supranuclear lesion. So we've got a degree of redundancy. So there's bilateral innervation of the nerve. So if there is an upper motor neuron lesion, then the opposite side will still be innervating will still be innervating the forehead, so the forehead will still be able to function. Whereas if there's a infranuclear or lower motor neuron lesion, then it's going to affect the entire face. So it might appear more dramatic because the entire face is drooping, but it's actually not a problem within the brain, it's a problem with the nerve, which can be, as we discussed, something called Bell's palsy, something you get oftentimes after a viral infection or any other number of problems. So case 7, we have a 21-year-old physics student that presents to you following several falls. On examination of the lower limb, you note that he has both flaccid weakness of the legs and hyperreflexia bilaterally. So this is quite a famous patient that you have here, and you're back in the 1960s, and this is actually Stephen Hawking. So you have both hyporeflexia and you have both lower motor neuron and upper motor neuron features. So something that can cause both of those to exist at the same time is, oh, we've already done that, is motor neuron disease. So the most common form of which is amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease if you're an American. And this presents with both upper motor neuron and lower motor neuron features. The pathology is the degeneration of the BET cells, so the upper motor neurons, and the anterior horn cells, so which are the lower motor neurons, so upper and lower. It generally happens to middle-aged people, though it can, I didn't mean to say infect there, I meant to say affect the younger patients. And other instances where both upper motor neuron and lower motor neuron features exist concurrently are in vitamin B12 deficiency and neurosyphilis, which we don't really see anymore. This is just one of the really bad features or bad predictors. Oh, okay, well, we don't need to see that anyway. One of the bad prognostic features of lower motor neuron diseases, is tongue fasciculations, because it shows that the head and neck are affected, but you can look that up on YouTube if you are interested. So we have a few more questions if you want to go back on the poll everywhere. And I'm just going to pause it briefly. So I can change the questions if I can manage this, which is a big if. Okay. Oh, I've stopped the share there. Sorry, bear with me. There we go. Can we all see that?
Yeah.
Cracking. So you perform a cranial nerve examination on a patient and note that their uvula is deviated to the right and their tongue is deviated to the left. On what side would the lesion be? So you have the options of right, left, and midline. Okay, well, if people are struggling to actually, oh, we got someone there. Okay, so with this, oh, okay, so tend to, so we actually find that, oh, I'm so sorry. Oh, for God's sakes, I'm really sorry. Computer's messing up. Okay, so what we actually find is the uvula deviates away from the side of the lesion. So it's going to be a left lesion and the tongue deviates towards the lesion, which is always a helpful thing. And that's just reflecting whether it's a contralateral. So if you think about which cranial nerves are involved, so we're talking the glossopharyngeal nerve for the control of the tongue, which innervates ipsilaterally, and the hypoglossal nerve controls the palate, which innervates contralaterally. So it's actually a left-sided lesion. Oh. So which of these pathologies would cause a flaccid right foot drop? So we're thinking flaccid, it's got to be a lower motor neuron injury. Right. Okay, perfect. Yeah, so it's a right common peroneal nerve injury. So that's going to cause a flaccid right foot drop. Right tibial nerve doesn't lead to a foot drop. A left radiculopathy would cause obviously a left issue because they're already decussated, and an anterior circulation stroke would cause an upper motor neuron issue. And then we have one last one. So which nerve roots are affected in Klumpke palsy? So if you recall at the beginning, T1, okay, that's cracking. So as we recall, it's a lower brachial plexus injury. All right, that's all I have to say. Do we have any questions at all? Well, thanks for showing up, guys. I realise it's been quite intimate. And thanks for listening.
Thank you so much, Adam.
Oh,
I know it has been very intimate. There's in the chat, guys, if you really don't mind, I think that was really wonderful.